Thank you very much, Anya, and good afternoon, ladies and gentlemen. I'd like to request from Marina, if I may, a copy of her drawing of the island. I see from that drawing that the coroner is in very deep water indeed. I wanted to say something first about what we're about in the medical legal system, which is basically what we do. We're investigating all sudden and unexplained and violent and unnatural deaths, not just healthcare deaths, but in all situations, including the workplace, the home, road traffic accidents, hanging, suicide, all unnatural death or sudden and unexplained death. Healthcare related deaths form, however, a very significant proportion of our work. In Ireland, this is done by a doctor or a lawyer. In England and Wales, the coroners are all lawyers, and hopefully we'll get some backup from the new medical examiner system in England and Wales, which has been set up at the moment. We've had some speakers from Scotland. I worked in the Glasgow Royal Infirmary, and I know the procurator fiscal system, which is unique, being a combination of both a civil law system and a common law system. So in England and Wales, it's the coroner. In Ireland, it's the coroner. In Scotland, it's the procurator fiscal. The common law world is the coroner, and the civil law world may be an examining magistrate or maybe a forensic expert. But all countries have some medical legal death investigation system in some shape or form. What distinguishes the coronial system is the last point there. There is a requirement, a mandatory requirement in most jurisdictions, not all, for an inquest in the case of unnatural death. So what we're trying to do is to provide a comprehensive death investigation system. That's what the public want, and it's what the families want, it's what the professions want at the end of the day. Although I think individual consultants coming down to controversial inquests might not agree in regard to their own particular situation. But certainly the public want that, and we endeavour to provide it as best we may. We haven't got the answer to everything, but I think we've asked a lot of the questions. Prior to Shipman, we were also asked in Ireland, in Dublin at least, to provide a check on the death certification system. And every day or every other day, certificates are bounced from the registration office to our office in Store Street for checking for one reason or another. We also provide public information on mortality and health and safety issues. Now, I've given a handout to you in regard to the reportable deaths, which really is the Dublin district, namely, although many coroners will have similar lists. And that means I can rapidly move on. You can read the reportable deaths. And I suppose the bottom line really is we have rules of law which are laid down in statute, and we've supported those with rules of practice to back up the rules of law. More recently, a few years ago now, we were asked to draw up a list of reportable deaths for the maternity hospitals because of their special requirements. So I won't go, I'll just say perhaps choose one or two of these headings. Fractures in the elderly provide some difficulty for us because there's not much public utility in investigating every fall or trip that occurs at home or elsewhere, resulting in a fractured neck of femur. But because the patients may die in hospital following an arthroplasty or whatever, this is essentially an unnatural death because the pneumonia or the urinary tract infection or the sepsis or the pulmonary embolus is the causative agent is the fall that occurred. And so we must have these deaths reported, but we don't always take the case. In other words, we do a preliminary investigation, and if there are no issues, a simple fall may be due to a trip, or maybe due to osteoporosis, or maybe due to a secondary tumor in the bone. So we look at all of the cases, and mostly we will permit the clinician to certify, provided there are no collateral issues on the part of any other party, including the family. More recently in our preliminary inquiries, we don't only speak to the professionals, but we speak to the families. That's been hugely productive, because you may get a completely different set of facts from the family as opposed to what you're getting from the doctors in the hospitals. It's been very useful to have expanded our remit in that regard. I think all of these speak more or less for themselves. The doctors in some of the teaching hospitals said to me many years ago, well, what will we do about alcohol? Alcohol is endemic. Alcohol misuse is endemic in our society. We haven't got the resources to investigate micronodular cirrhosis or bleeding varices. So they said, well, what will we do? And I said, report the deaths to our office, but we won't be taking very many of them. We do look at acute alcohol poisoning or acute intoxication, or if there's any issue of care issues or injuries, that sort of thing, but mostly the doctors will be certifying. Because of the Eighth Amendment, in Ireland, the fetus in utero has the protection of the constitutional protection, and we are concerned to get reports from the maternity hospitals in these areas. And of course, hypoxic encephalopathy brings in some very complicated investigations and inquests. As you probably know, some have been highlighted very much in the media just recently. I'll come back to that in a moment. So these are the rules of practice, and you can read that. You can read those lists for yourselves. This is what a lay person thought we were about. He's a civil servant, senior civil servant, who listened to us for 2 years when we were reviewing the coroner's service. And I thought you might like to read it. It's for the living, though we're investigating death, and it's a forensic and medical legal investigation with those functions. That's a flow chart of what happens in our office every day. DR is death registration. It might happen directly after or soon after the report because there are no issues. The doctor may be in a position to certify the death and no collateral matters arise. If the death is going, let me see if I can illustrate it for you. So this is the medical certificate of cause of death and the registration. If on the face of it, it's an unnatural cause, it will go to autopsy. If it's dubious, it'll go to autopsy, and if it's a natural death, the coroner will certify. If the death is unnatural or there are collateral issues, it will go to inquest. These are the only data we have. There are many, talking about healthcare-related deaths, there are many. I was looking at our database recently. There are hundreds of cases of healthcare-related matters on our database, but I have no analysis. We have no dedicated coroner's database. But those are the figures for 2015 for our office. Just a word about the medical certificate of the cause of death. Many of you who are signing off on these will be familiar with the format. So A, B, or C must indicate the underlying pathology. So if the mode of death is given as cardiorespiratory failure, B must show what the underlying pathology is. And so when I speak on grand rounds or elsewhere to doctors, or GPs. I say, look, there's one take-home message from this talk, and that is that the medical certificate must show no unnatural cause of death. Only a coroner can certify an unnatural cause. Now, you may say, what about the old person who has the fractured femur? Well, in that situation, the coroner may give permission for the death to be registered, but will cover that by what we call a pink form procedure, so that the registration office will know that we've been informed about it and have cleared the death for registration. The issues really are proximate causes being given rather than the underlying cause, unclear terminology, and the registrars will bounce the certificate to our office because the certificate might intimate that what happened might have been a complication of a procedure. Mesothelioma. You'll be amazed how many senior doctors write certificates for mesothelioma, forgetting the role of asbestos in the etiology. 95% of these tumors, perhaps 100%, are due to exposure to asbestos dust in the workplace in the past. And we're having a peak in Ireland now in relation to these deaths, which must go to inquest under our law. And then incomplete certification. What does cardiomegaly mean if it's not qualified? It could be high blood pressure, it could be a cardiomyopathy, it could be valvular disease, or it could be cocaine, chronic cocaine usage, or chronic alcohol usage. We want to know what is the cause. Intracranial hemorrhage is useless. We want to know whether it's intracerebral, subarachnoid, subdural, or epidural, because they all have different etiologies and connotations. And what about HIV and Hep C? We want to know the causation. Was the deceased patient a drug abuser, or had he or she received contaminated blood products at some stage? Or was there some event? Was it a tattoo, for example? Whatever. Spongiform encephalopathy is prion disease. Why do we need to know about that? CJD, in other words. Well, some of it is related to contamination of the food chain. And variant CJD is related to variant CJD related to food chain contamination, or the CJD may be sporadic, which we're not interested in, or it may have been sustained as a result, again, of a contaminated blood product. So we need to know more about what's written on the cert. We need an explanation of what has happened to the patient. I asked some of my staff just a few days ago to pull together a few medical certificates that have been bounced to us in the last week or two. And just very briefly, the first one there, acute and chronic subdural, obviously needs to be investigated, probably a fall or some other incident. The second one raises the issue of how the hepatitis was transmitted. This was what is immune-resistant encephalopathy? That needs further explanation. But look at vertebral fractures at number 2. And then intravenous illicit drug abuse. No doctor can certify these causes of death, so they're now under investigation. So the deaths under medical care form a large percentage of our work. A great deal of effort is put into getting in medical reports, autopsy reports, obviously, and perusing the case notes and the nursing notes, etc., trying to work out what happened. I'll just address the last point there. We get a lot of interaction from families, either verbally, emails, or by writing in, complaining about the health service. We're not ombudsmen for the health service, so we're not concerned with minor grumbles about issues in hospital or maybe minor communication issues. Whatever is alleged must go potentially to the cause of death. So we do filter out all these complaints and only adjudicate on the ones that may be relevant to what we're doing. There's a lot of dissatisfaction, and communication issues are a big problem in our experience. So the deaths on the medical care may be associated with medical or surgical treatment. Maybe due to a lot of the ones I remember most vividly were complications of invasive diagnostic or therapeutic treatments or procedures, or maybe due to an adverse drug reaction or anaphylaxis or a drug interaction. And yesterday I was listening to the polypharmacy issue, and that's an issue that is really beginning to make itself heard at the moment in coronial work. And I think we'll be hearing a lot about it in the future. Polypharmacy and drug interaction. And of course, we look at any non-medical injury sustained in hospitals. The Health and Safety Authority, of course, may be involved in the latter. We do interact, obviously, with our pathologist and try and get information and get the case notes and anything else that's required. That will speak for itself. The conflict of interest is when the families say, we do not wish to have the autopsy performed in that hospital. But obviously, they're dissatisfied. There's a lot of angst and aggravation. And I consider the pathologist to be my pathologist when I direct an autopsy, but the family might have a different view. And so we have to move the location of the autopsy from time to time to cover that. Also, the pathologist might have an issue, him or herself, because of the interaction with the clinicians, etc. Or they may be aware of things that have occurred in the hospital. So sometimes we do have to look at that. So prior to an autopsy and a healthcare-related death, we have standing operating procedures, some of which are here. All tubes, airways, and lines must be left in situ. And when equipment failure is an issue, we want that secured and isolated. And we do have, if on investigation, it looks as if there was or could be an equipment failure issue that caused an adverse event, then we do take that instrument for further examination. I have a number of items out at the moment for expert examination as we speak. And we also ask the hospital laboratory to obtain all tissue specimens, particularly blood and urine, lest we need toxicological analysis. So really, it's every adverse event that might or may have, our fence is not very high, that may have contributed to an adverse, the incident may have contributed to the death in some way. Obviously, it will require a preliminary investigation, an autopsy, and maybe an inquest to sort it out. And maybe we won't be able to sort it out at the end of the day because of patient comorbidities, etc. And these are the areas: CP lines, perforating veins, chest drains causing pneumothorax or hemothorax, peg tubes, not in the right place. The feeds are going into the abdomen rather than elsewhere, into the stomach. Cardiac pacemaker issues, etc. Coiling of aneurysms may rupture the aneurysm. All of these are grist to our mill, really. We would review before going to or deciding on an inquest, we will review all the relevant documentation, autopsies, medical reports, and then we often receive written or on a mention of the inquest, oral submissions from legal representatives in relation to issues arising. And we have to hear these and make a ruling on them. We'll then make a witness list of the relevant witnesses, get in the case notes, x-rays and scans, etc., which will be exhibits at the inquest. And from time to time, we may need an expert report on a particular or net point, technical point. Now, the coroner's expert is an expert for the coroner and not on behalf of any of the parties, and will usually be asked not to review the entirety of the case, but a particular technical issue or matter that might need clarification. I will, in the interest of time, you can read that. It's a seminal case indicating the scope of the inquest. And just to say, perhaps to explain to those who mightn't know, we're an inquisitorial tribunal at law. So it's not adversarial. We're inquiring into the facts of what happened without consideration or adjudication on civil or criminal liability on the one hand, or exoneration on the other hand. So we're not saying that anyone is to blame or not to blame. We're establishing the facts, placing those facts on the record, bringing in a proper finding or verdict, and then making representations by way of recommendation or rider to the verdict if that or they are appropriate. So we may make one recommendation, we may make a number, we may do a narrative verdict, but we must address issues, controversial issues at the inquest and try and resolve those issues. Not always can that be done, but we will often make recommendations in relation to, for example, review of guidelines or protocols or procedures. And this is what the Supreme Court has said is the public policy consideration underlying the holding of an inquest. So it isn't just the cause of death, it's to allay suspicions or rumours or issues around the circumstances of the death, and to draw attention to circumstances which, if unremedied, might lead to further death. And interestingly enough, to advance medical knowledge. We get a lot of the hard cases in the coroner's court. And this policy consideration allows us to take perhaps a wider range of cases. There may be some lack of clarity in regard to what happened, and we can take that case and investigate it. And when I'm speaking to the hospital staff in relation to the legal interests of persons, I always say the other interested persons might be yourself or your colleague or the hospital board. We try to establish, if we can, the cause of death. That's not always straightforward. Look at the circumstances, comorbidities, etc., the medical and surgical treatment, and what role, if any, did the procedure play in the adverse event? And it may be that there was no procedure. So it might be that, well, why was a particular procedure not carried out? So it's it's commission and omission that we're looking at. So I wanted to give some examples from our recent files. I just anonymized them for today. Cause of death is a left-sided hemothorax. It was an inquest, an insertion of a CV line into the internal jugular vein. I think they were changing the lines, as far as I remember. Guide wire perforation of the jugular vein, and hemothorax, local bleeding, hematoma, etc. Complication of the procedure. Cause of death, disseminated cytomegalovirus infection. Inquest, why? It's natural causes, isn't it? Well, this was a stem cell transplant. The patient was immune deficient because of those things, and developed rampant CMV pneumonitis, and CMV was, I think the pathologist said, widespread cytomegalovirus infection and cytomegalo-pneumonitis as the cause of death. It came to our knowledge that there's a typographical error in that slide, which I will correct. It should read conditioning chemotherapy and pre-transplant test. The transplant testing had shown that the patient was CMV positive. So there was a transcription error because although 2 persons had reviewed the relevant documentation, I think it was just overlooked. And also, teeters were arising as things became stormy in the ICU, and that wasn't checked because the error wasn't noticed. And so we asked that the team would review their pre-testing protocols, and I understand that has been done, and preemptive CMV testing is done now as well. Cause of death, septic shock, pancreatitis, knee replacement, post-operative wound infection, cellulitis, etc., VRE. We have a lot of these cases. Lethal level of lamotrigine. This patient was found dead in a hospital bed. I think it was a psychiatric unit. Had a history, as far as I remember, of seizure, and was being treated with anti-epileptic medication. We looked at all of the issues, the dosage of the medication, how it was administered, was there any accumulation or secreting of the medication by the patient, was it a suicide, was it something else? We looked at sodium valproate, which wasn't on the original toxicology report because it wasn't done in the particular laboratory, so we outsourced it. The levels were normal. There were no lamotrigine levels done because it's not normal practice. However, on contacting pharmacovigilance, we were made aware that there is a product characteristics document, which is not the sheet that comes with the medication. It's a really voluminous piece of material which specifically relates to the issues with the coterminous or administration of valproate and lamotrigine. So I read it, and clearly there were guidelines set out of what should be done, and it wasn't mentioned. All I'll say now is it wasn't mentioned, at least ad initio. So I don't know whether that was really taken into consideration by the clinicians. So what it implies is sodium valproate interferes with the gluconization of lamotrigine, so it's likely that this was an ADR, adverse drug reaction. Subdural, I just 2 or 3 slides to show you what you could transpose this to a surgical death or a procedure death. This is a fall in a long stay unit of a hospital, multiple rib fractures, falls at home, risk assessment initially moderate, raised to high, on medication with cognitive issues, on warfarin with a prolonged INR, I think on admission. Posey alarm was removed. There was no alarm mat beside the bed. The escorting of the patient, all of these came in for scrutiny at the inquest. And ultimately, we did ask for a review of protocols and procedures. These are common type inquests in the coroner's court. Mechanical obstruction of the airway by a food bolus in a tertiary referral hospital. Cognitive impairment, Parkinsonism, admitted as a result of a fall. The interesting thing about this was that the base hospital had done a speech and language therapy assessment, and there were concerns about saliva management, and there were 4 documented choking episodes. The Tertiary Farrell Hospital had similar concerns about the swallow issue. But the family wrote in and were vocal at the inquest saying that, you know, the patient, they were there at meal times, and the patient got a rasher with a lot of rind on it, and on one occasion got a sandwich which was in cling film. So there were all the sorts of issues that we went into before making the finding. And self-harm in hospital looms large, in regard, especially in psychiatric hospitals. And again, we would look at the procedures and practices, etc. And just to mention the perinatal deaths, which really exercise us, when I see hypoxic ischemic encephalopathy on the autopsy report, I know this is going to be one we have to really investigate. So I put down on your list and on the hospital list just recently hypoxic ischemic encephalopathy. I suggested that to the masters who asked me to do the list some years ago, and they were horrified that I would be thinking of putting that down, but experience has shown otherwise. So it's now on the list, and all these deaths due to cerebral hypoxia or whatever must be reported. And we would go through, this is a case. There were issues about the CTG tracing during the oxytocin augmentation and the fetal scalp monitoring issues. And we asked those be addressed because they were factors in the sad outcome. So there are many, just to finish, there are many academic groups and organizations and projects being researched in our office. We've opened up our files many years ago. There's a lot of information in coroner's files, and so we feel that the outcomes need to be recorded and quantified and examined in a quantitative and qualitative way. So then the HRB began in the, I think, 2003 with drug-related deaths and have more recently extended their inquiries to alcohol, road traffic collisions, fires, and self-harm. I was in Europe recently, and I understand that we have some of the best drug-related death statistics in Europe as a result of this initiative. And we have a lot of other interactions with various bodies who are doing health-related works and projects and making recommendations in regard to protocols, etc. And I suppose the only thought I would leave you with is that there is a lot of surveillance data in our files. Thank you very much indeed.
Okay, thank you very much for a really excellent talk. I've certainly taken away a lot of homework that I'll need to be looking at over the course of the next few days. We'll just open the floor for any questions. Just Olive.
I have to wait.
Yes. Thanks.
Yes. Thank you very much for that. I suppose for people who don't know me, I'm a patient representative in the room today, and we went through a public inquest with my dad when he passed away. He was in a hospital when he passed away after a surgery. I suppose when I'm listening to everything being said there, I suddenly was made aware of things I didn't know, like the conflict of interest. I wasn't aware that there was an opportunity there where we could have even had a discussion around, you know, the inquest or who was doing it. And I'm not sure if that is even the case. From listening to you, I'm still a little unclear there. Also, we weren't ever given anything when the guards came in and we had to do the identification of the body and we were told about what was going to happen. We weren't given any information about what an inquest was or that an autopsy would have to be done. And after the funeral, we were still very confused. And I suppose from a patient's perspective, when that situation occurs, especially in a healthcare setting, I think it would be really, really useful for somebody to sit down and actually say, okay, this is the process, this is what you do next, and what options are available or not available. It was quite stressful, and even when we did get to the coroner and speak to the coroner, he wasn't aware that we actually had any concerns ourselves. When we spoke to him, he was just told that, you know, he had died through unnatural causes within the setting, but didn't realise until a few months later that we had actually serious concerns as well. So that, just listening to you, I suppose, makes me think of other patients or carers, I suppose, of loved ones who might have passed away, and I don't know if anything might be done about that.
I don't want to ask you what district it was, so don't tell me. That we have, there's the material on our website in relation to inquest, and we have booklets for families. So, we would be prepared to talk, because I'm sorry you went through that. That's all I can say.
Just if for other people in the room, health professionals in the room, not yourself personally,
yes.
that at the point of care, at that point, it would have been very useful for a health professional at some level within the hospital just to sit down and give you the leaflet.
Oh, I see.
So you don't have to go trying to figure it all out yourself when you're going through a traumatic time already. I think that would be something, if somebody would consider looking into that, it would be very beneficial, in my opinion. But thank you for your presentation. It's opened my eyes
Point
a lot.
noted.
Thank you.
Actually, just on that, thanks, Ellen. Just on that, do you think that staff and family members are sufficiently prepared for inquests, in your opinion?
They may not be. We do try to help as best we can. We have a staff who have an intense interaction with the public and with families. But I mean, we can't obviously reach everybody. We have booklets, we have a website. But I'd be anxious to get some feedback, and we'll try and address the issues if we can. But sure, I agree. Not all families take it in or are aware of what facilities are available. So we need to improve in that regard.
Excellent. Now I have another question from the floor. There you are. Yeah. Hello.
Good evening. Jerry Clark is my name. I work in social care here at HSC. Thanks very much for your presentation, Dr. Farrell. In the context of having investigations carried out, it is my experience in my current role that on occasion reference is made to the coroner requiring an investigation not to be completed until such time as the inquest is concluded. So I'm wondering, is there a standard process that we should be complying with, or is it something that we should engage with coroners to have clarity around this issue? This does create significant delays for families who have lost loved ones. It creates delays for us in terms of having investigations completed and find out causes of where things go wrong and for learning purposes. Thank you.
Is this an in-hospital inquiry?
This would not necessarily be a hospital piece, but would also be within the community setting as well. So.
Well, just to take the first one, we're not concerned. You're in having an in-hospital inquiry. We're not concerned with that. We're also not wishing to necessarily to see the results of it, because we're going to have our own inquiry. We'll make up our own minds. But I'll read anything that's proffered to me. Now, if you're talking about the community, I'm not really sure what the point you're making.
There will be situations whereby there would be an inquest pending, and in that situation there would be investigation that would be on hold.
What investigation?
For example, in a residential setting.
In a residential setting?
Yes.
Well, no, we've no hand, act or part in that. That's a matter for the institution.
Okay.
Or the health authority.
Okay. All right. Thank you very much for that clarity.
Yes.
Thank you.
Any other questions? No? Then just one final one from myself then. There would be a perception that inquests are turning into media trials. What would be your comment on that?
Well, I do understand this is on the concerns on the part of some clinicians who have been through a difficult experience.
Yes.
And I do empathise with that. I think clinicians are often traumatised by inquests, or sometimes. But I think in my experience, mostly they have been, at the end of it, I could see the parties shaking hands, and there's great, so not all inquests are like that. If they're high profile or controversial, all we can do is try and keep things as calm as possible. But as regards your question, are they turning into high profile trials? I hope not, but I understand the perception.
Yes. Okay, thank you very much indeed. If you put your hands together again for Dr. Farrell.
Thank you very much.
Thank you very much indeed.